Welcome everyone. My name is Chris McDonald and I'm a professor at Ryerson University's Ted Rogers School of Management, and I'm the director of the Ted Rogers Leadership Center, in addition to being a member of the board of directors of the Canadian Centre for Ethics and Corporate Policy. And it's my pleasure to welcome you today and to introduce our panelists. Before I do that, I'll let you know that the webinar is being recorded, but only the people you see on the screen are being recorded. You folks at home are not. That's how things will work. There'll be a time for Q&A at the end, and the questions themselves, if you post questions in the Q&A function, those won't be part of the eventual recording, that's that. So let me do some introductions. Our moderator today is Nancy Walton. Nancy Walton is the Associate Dean, Student Affairs, in the Yates School of Graduate Studies here at Ryerson, and an associate professor in the Daphne Cockwell School of Nursing. Her areas of research and interest are priority setting and decision-making in healthcare, the experiences of parents of children with disabilities, and ethical considerations in the use of new technologies and innovations in healthcare. Now, in addition to Nancy, we've got three really outstanding panelists today, and they all have tremendous CVs, but I'm going to keep the introductions very short so we can get on with the discussion. Maureen Charlebois. Maureen is the Chief Nursing and Clinical Officer at Bayshore Healthcare, one of the country's leading providers of home care, pharmacies, and community care clinics. Maureen has over 30 years experience in both public and private sector clients at the organizational, provincial, and national level. Julia Hennigsberg. Julia joined Toronto's Holland Bloorview Kids Rehabilitation Hospital as its president and CEO in 2015. Holland Bloorview is Canada's largest pediatric rehabilitation hospital, serving children and youth with disabilities and complex medical needs. Julia is a three-time Women's Executive Network Top 100 Most Powerful Women honoree. John Yip. John is president and CEO of Kensington Health, a nonprofit community-based residential and ambulatory health services provider. John has over 20 years of healthcare experience in the healthcare industry, leading system and organizational strategy and change. Nancy, I'm going to turn it over to you now.
Great, thanks, Chris. So before we begin the discussion, I want to start with the land acknowledgement. I, of course, want to acknowledge that many of you are likely joining from various places, not necessarily where Ryerson's located, and I would encourage you to visit the website native-land.ca, which is a resource for anyone working and living in North America to find out more about local Indigenous territories and languages. I'm going to be using the Yates School of Graduate Studies land acknowledgement to acknowledge the land that Ryerson's currently on, and this has been developed through the voices of two of our Indigenous members of Ryerson's graduate student community. Megan Lewis, who's an alumna of the Masters in Public Policy and Administration program here at Ryerson, and Riley Kucharan, who's our graduate school's Indigenous advisor. And Riley is a communication and culture PhD student, also a professor in the School of Fashion. Toronto, or it's traditionally known Tukaranto, meaning where there are trees standing in the water, occupies a place that has been home to Indigenous peoples for over 15,000 years. The Huron-Wendat, the Petun First Nations, the Seneca, and most recently, the Mississaugas of the New Credit River. The territory is subject to the Dish with One Spoon Wampum Treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share and protect the land. Subsequent Indigenous nations and peoples and settlers from all over the globe have been welcomed into this treaty in the spirit of peace, friendship, and respect. Tukaranto is now home for many First Nations, Inuit, and Métis peoples. Recognizing where we stand as we do is not to historicize the experiences of Indigenous peoples or to offer platitudes or merely as a formality. It is one of many intentional acts that we do to acknowledge injustice and to commit ourselves as individuals and collectively as communities to the path of truth and reconciliation. Thank you very much. So let's get started. It's so great to be here with these three healthcare leaders and with many of you attending. I think we have over 100 people attending, which is just great. So thank you for spending your time with us today. Of course, having these three people here with us, one of the key things we'd want to talk about is ethical decision-making. Of course, being in any kind of leadership role, especially in healthcare today, The idea of ethical decision-making is key and probably a part of your daily lives. Anytime in roles like yours, ethically challenging decisions have to be made. And so when we're thinking about over the last 15 months in a time of crisis, you've likely had to make some really challenging and difficult ethical decisions about how to allocate scarce resources, including human health resources. So the first question, and I'd love to hear from Julia first and then open it up to Maureen and John. Can you talk a little bit about some of the challenging decisions or the resource allocation or priority setting decisions? What have they looked like in your organization over the last year? Julia.
Thanks, Nancy. Nancy, thanks, Chris, and the Center for the panel. And Nancy, I really appreciate that land acknowledgement. It was a great teaching, really wonderful. You know, as I was thinking about this question, I'm going to ask us to cast our minds back to March 2020, when we were all much younger and when things were very different. And there were two things in and around that time that I'll never really forget, leadership moments from my team. The first relates to our staff, and the second relates to programming. And as Chris said, I'm very proud to work at Holland Bloorview Kids Rehabilitation Hospital. And we have a number of unique services, the kinds of services that if they're not being offered, they simply don't exist for children and youth. And in and around the March break time, we have a number of respite and recreational and rehabilitation programs that are that take place over March break. And we were determined that those should continue to happen in March 2020 because they are truly programs of last resort for children. And up to about the Thursday before the Monday of March break, we were planning to have them continue. Lockdown, stay at home had been ordered. We had made the internal determination that these were essential programs required for the health and well-being of those children. And then we were instructed by the province to ramp down all non-emergency, non-urgent services. And we had to then interpret that order and make the decision to cancel all of those programs for those kids. So it was those kids not receiving those services, those families not receiving that respite, team members who had been hired specifically for those programs who had unique skills and trying to figure out how to address that. So it was a sort of early on, I'd say, crushing blow for our team who were really trying to balance safety and welfare and challenging government decisions with their own ethical and moral responsibility to their clients. And it was a time of feeling, I'd say, very out of control. And it was very much in the early days, within the first week or so of the stay-at-home order. In and around the same time, I was rounding on in the ambulatory clinic area of our hospital. And I quickly was surrounded by about 35 or 40 staff who came out of their offices. And they wanted to know why they were being required to come to work when there was a stay-at-home order. And businesses were telling their staff to stay at home. And the message out in the media was that the right thing to do, the moral, the ethical thing to do was not to go to work. And what was wrong with me, what was wrong with Holland Bloorview, that we were not being consistent with that. And I probably spent about 45 minutes or an hour surrounded by these staff, many of whom were tearful, many of whom were desperately afraid to get on transit, to come to work, to engage with our clients. And I stayed there till I'd answered every question, not to people's satisfaction, because for some people there was no satisfaction in having to work. And one of the conclusions that I drew out of that, and there'll be more to talk about over the course of this hour, was in the course of the pandemic, we have all in different ways individually been confronted with who we are and what we do for a living, what is essential, what are our ethical obligations in terms of our professional responsibility. And some people have had the experience of confronting their professional identities in ways that were very unexpected. And so part of what was experienced in that moment for me and for those, several dozen members of my team was Who said I was an essential healthcare worker? When did I sign up for that job? And who are you to assign that to me? So, those are a couple of examples. I think there'll be more time. I'm going to leave it there for now. There's more time to talk about more recent examples, but it's a really interesting kind of thought experiment to cast one's mind back to 14 months or so ago and where we were then, at those times in some of these decisions.
Thanks, Julia. And I think, and we're going to go to Maureen next, but I think a couple of things out of there. One is the idea of the different quality of, or the different type of decisions back then and how much has changed. And so hopefully we'll get to some of those more recent examples as well. And just this idea of what is essential, what then are our ethical obligations, and looking through a different lens. So really a great answer. Thanks. Maureen, please go ahead.
Yes, so I would comment that, we've been confronted with ethical decision-making throughout the pandemic, right from day one back in January through to today, dealing with vaccines as an example. But I think I'll share sort of where we started. And personally, it was really an ethical leadership sort of dilemma for me, which then impacted certainly healthcare resources as well as resources to provide our staff. And it really started in January when I joined the organization. I actually came from the hospital sector and was just on the job for a couple of weeks when I sent out my first memo to say, I'm hearing of this virus from Wuhan, China. Just want to give everyone a heads up. We may need to get ready. To all of a sudden early days in March and not knowing what we were dealing with, we had to make a decision about what to do. And that was to lead really with the precautionary principle. And until we knew, we actually implemented contact isolation precautions, droplet and airborne. And that was fought with a lot of questions and resistance in the sense that we provide services across Canada. And in many provinces, we hadn't actually been received direction from the ministry, direction from public health, because home care wasn't first out of the gate really thought of. And so I had a lot of challenges, even internally with our leadership team to say, well, we can't do that because, our funder isn't supporting that and they're not going to support wearing N95, to the other extreme to say, we don't have enough PPE. And so we had to do everything possible to continue to put the top of safety top of mind for all of our staff and all of our clients. And as well, early days when there was public policy, as an example, that came out to say that all citizens that traveled, internationally had to be put on quarantine. Well, all of a sudden, I wake up in the middle of the night thinking, oh my gosh, what happens if that's the home where we're sending a nurse in to care for their patient, client, and their family member is on quarantine? Well, we had to implement a policy internally to say that all healthcare providers going into homes that have a family member or household member who is on quarantine, they have to wear full PPE. And so that's been a real challenge, and also a challenge of different policies and public direction, and dealing with provinces across Canada has made it challenging. But what kept us focused was safety, and I think because of that, our leadership team has done a tremendous job of leading with what is right when sometimes we don't have all the answers. And I think that's made a tremendous difference, and why I think, in home care, our numbers as far as exposures for clients and exposures to our staff have been fairly minimal.
Great, thanks, Maureen. And yeah, I think we could probably have a whole other session on sort of ethical leadership and those challenges, especially across, multiple jurisdictions. So thanks for that answer. John, do you want to chime in here?
Thanks, and thanks for the center for inviting me. It's a great opportunity to share some of the stories from the last 14 months. So I'm going to go back to where Julia was back in March, and we have a 350 bed long-term care home, and we were hit hard and early, right from the onset. And so one of our units, we have a 25 bed unit, there was one positive, and within 24 hours, it was 3, then went to 8. Eventually, the entire unit was positive as a dementia unit, so very complex individuals living there. So the first day I went up, usually on the unit of that particular unit, because of the complexity, we have about 6 or 7 staff there on a normal day. When I went up there were only 2. And I kind of looked around, I just went, you got a problem here, a real big problem. And then just by happenstance, I had come at a mealtime. So I rolled up my sleeves, worked with the 2 other staff, and started feeding those residents that couldn't feed themselves, that normally family members were there or the staff were there to help. There was no one to help. And so for the next 103 days, my evening job was residential aid. I fed, I cleaned, I moved trays, I moved residents into their rooms so they could isolate safely. And I think that really set the tone for all the decisions that came after. I was able to see and witness firsthand at the bedside the challenges, the fear of the staff, the fear of the residents, talking to loved ones by iPad to say, here's what I'm seeing. I'm not a clinician, but this is what I'm seeing. And watching our staff work tremendously hard to provide the quality of care that every single resident deserves, COVID or non-COVID. But it is seared in my memory of what happened in those 103 days. And as a result, I see things very differently. Had I not been on that floor, I think I would have approached it a little bit differently. But having been on the floor and interacted side by side with staff, some of the staff, and when I first went up, you can't see anything, you just see the eyes. And one of the PSWs chewed me out, said, you're not doing this right, you're gonna get sick. You're not donning and doffing properly. And said, who are you? Like, I've never seen you on the floor. What's your name? I said, it's John. And she goes, John, you really got to pay attention. I don't know who trained you, but I got to teach you something here. It's going to save your life. So I listened and did it. And then she turned around and said, what's your name again? I said, it's John. And John what? I said, John Yip. Her eyes kind of bugged out. Her face turned red. I said, are you the CEO? And I said, I am. She goes, oh my gosh, I'm so sorry. I didn't mean to talk to you that way. I go, look, I am so glad you talked to me that way. And it gave me comfort to know that PSW who could tell me to don and doff properly, that unit was going to make it. And eventually it did.
That's an awesome story, John. And I'm glad you learned to don and doff your PPE properly. It is really, really important. I'm picking up a few words and we're going to move on to the next piece, even though I think we'd love to hear more of these narratives. John, you talked about tone and setting a tone as a leader, which is, always important, but especially important in times, I think, of uncertainty. Maureen, you talked about a focus on safety, like the North Star. What does the North Star keep people focused on? What is the driving thing right now? What's a focus when there's a lot of uncertainty and anxiety? That's helpful. And Julie, you talked about like being there and answering all the staff's questions and really helping them think through obligations. So I think those are 3 really, really important things. So I really appreciate your answers there. We're going to move on a little bit to partnerships and collaborations. And for many of you who are attending, you've probably seen in the media stories about critical care patients in Toronto, wherever you're from. You've probably seen these stories being airlifted to Kingston or Windsor or Ottawa, opening up collaborations that haven't typically been there on a daily basis, or children's hospitals opening up adult units, ambulatory care hospitals opening up overflow ICUs, things like that. So I just want to ask you from your perspective, and Maureen, as I said, I'd love to hear from you first, given the home care focus. Can you talk a little bit about some of the partnerships and collaborations that have emerged over the last 15 months or so? Were there some new or unexpected collaborations that helped you get through? Were there existing partnerships or collaborations that were strengthened? So if you can talk about any of those sorts of collaborations, that'd be great. Maureen.
Yes, so I would say first, my first collaboration was actually with the Emergency Command Center in Ontario, and that started just because I was, new to the sector and new to Bayshore, and just to find out what was happening, and also to ensure that we were not forgotten about. And then the second collaboration was really reaching out immediately to our other home care providers, just to really build that sort of connection, that network, and that we had a forum to speak to one another, because things were not always coming to us, and we had to quickly, decide based on some other set directions to long-term care, to hospital, that we could leverage and put forward in home care. But what really was easier to do was already those natural relationships and partnerships that existed. So we have a lot of direct partnerships with our hospitals. And so we were able to really leverage those and to help expedite the safe transfer from hospital to the home, as well as to our transitional care units. And so that really helped, obviously, through the throughput, and also to support those safe transitions from hospital to home. We also, as I'm sure we've all heard, what sort of was the number one reason for the advancement of virtual health. Was it, the CEO, the CIO, or COVID? And it was definitely COVID. But we were very fortunate because we already had a very good digital health platform for our patients and families. So we were able to leverage what already existed. So for example, in Ontario, through our digital health care at home platform, our nurses support oncology patients to stay in their home, and that's all through digital means. And so we were able to offer that as a solution to Health Canada, and quickly built a partnership with the Public Health Agency of Canada last year. And we did all the remote digital support through the Care Path at Home for all of the travelers that were coming back into Canada that needed to be quarantined. And, our team did that within weeks. So we were able to scale up very, very quickly. And similarly, we also have both medical and nursing personnel that we were able to augment, and early days provide staffing into the long-term care homes. When you heard just John's story there, they were in dire straits. So we were able to step up and provide staffing there, and as well in our Northern Nursing and in our National Defense. And in fact, one of our nurses just won a award to recognize her leadership and dedication through the COVID pandemic. So I think definitely trying to do something new was very hard, like a new idea, a new model, because people were just trying to, we're staying focused on doing what we did, but we were able to scale up on those areas that we're already doing well. So lots of other great examples I can give you, but I'm sure the other panelists may want to comment on some of their partnerships.
Great, thanks, Maureen. John, do you want to go ahead?
Sure. So I'll just continue my story. It's like 14 months of stories. And so when I went to the floor, I was like, well, we've got a whole separate division. It's an ambulatory surgery division, and they're very distinct and separate entities. So wave one, we had to furlough 100 staff because of Directive 2, which is to shut down all non-urgent surgeries. So we had surplus staff. So I said, look, who can help? So the partnership is actually an internal partnership where 20 staff from our ambulatory division put up their hand and said, we'll help. One such individual, his name is Joe, his actual name is Joe, 30 years in the Toronto Fire Service, also part-time ICU nurse on weekends for 30 years, retired. His wife kicked him out of the house because he was antsy, and came to work at our eye institute part-time. He was one that put up his hand, went to our COVID floor and worked 200 days and anchored that floor. He is a trained nurse, has all the certifications, and was soon really being that leader, spiritual leader, physical leader, and just mobilized that unit. Fast forward to now, he went back to do eye surgeries, but with this recent wave, I asked again, who can help our hospital partners? And guess who volunteered first? Joe. So Joe's working at the ICU right now. And the second quick example is, I can't not talk about partnerships and not mention Women's College Hospital, who came in and deployed 20 staff into our home, PPE, testing, and we actually share a nurse practitioner as a result. So we're really, really thankful to all of our partners internally and externally during this pandemic.
Great, thanks, John. I'm seeing a nursing theme coming here. Julia, please, let's hear from you.
Maybe from a couple different perspectives, and with an eye on children and pediatrics and child health. One is, Maureen made mention of the emergency management structures, and those existed across the provinces, across the different regions. And so for the first time ever through the incident management command structure, we had in the Toronto region line of sight into every pediatric bed in the region. And we never had a way to know that. So the ability to look across those beds, to understand what the needs are, to transfer young people among those hospitals, we literally had never had a mechanism either to have that information or to make those kind of changes. So that's a sort of emergency management structure example of, I'd say, forced collaboration because of the emergency. The second example I'd like to give is of what I think are new but will be more durable kinds of relationships. And so pretty early on, we started meeting as the CEOs or presidents of the 5 children's hospitals across the province. Information sharing, resource sharing, understanding what was hitting us. For those outside of Toronto, Toronto kind of, it was always first in Toronto, whatever bad thing was going to happen started in our region. So I think those relationships became really important, and I think will be durable past the immediate emergency. And actually out of that, we ended up forming, along with Children's Mental Health Ontario and Empowered Kids Ontario, which represents children's treatment centers, a children's health coalition that came together for advocacy. But among other areas, one of the things that we've, I think, been an influential voice on has been the importance of in-person school for children. And so the language of first to open, last to close came from this coalition. You hear it come out of Fanny Brown's mouth, you hear it come out of David Williams' mouth now. That was our language. Don't open restaurants if you're going to keep schools closed. You've got it wrong. And the emphasis on the importance of school, not just for education, but for child development, for children's mental health, et cetera. So that's an example of partnership that I think will be continuing and durable and impactful. And I'll just give you one last short example, and those are more episodic examples. So if you were in the Toronto region, you'll probably remember back last spring, Participation House, which is in the northern part of our region. That's a group home for adults with disabilities. And they went into a crisis of COVID outbreak and they had no PPE. And our materials management, infection control people quickly came together, and we were very scarce on PPE at that time. Again, this was the beginning days when we were asking our clinical staff on the units to reuse their masks. Our team came together and said, we need to put together a donation for Participation House. And they pulled it together. One of our staff who worked in Aurora brought it to them, brought it to the Markham Stouffville Hospital shipping, receiving area on his way home. And they had to do that. Similar, we came together and did a PPE donation for First Nations on Reserve Community Health Service. So I think there were those collaborations, that relationships that did not exist, that came together for a singular purpose around a crisis where people were sharing scarce resources. It wasn't like there was any excess in the system. And I think that's has been a really important thing that we've seen throughout the pandemic.
If I could just add to that, just building on, your experience with Participation House, just as an example, we actually had staff that stepped up and went in to provide care at Participation House. And so we may not even knew that was a formal collaboration, but it was just to show, the human spirit, and that everyone just stepped up to do what was right. And that was to take care of people that were in need, and they put their own life on second, and those first that they had to care for. But that's what our healthcare workers do.
Thanks, Maureen. I have to say, and I'm sure the audience agrees, really appreciate those three really diverse sort of look at partnerships and collaborations. And just to pick up on some of the keywords used, John, you talked about internal partnerships and this idea of collaborations and partnerships being strengthened by people that you work with every day in a particular way. And Maureen, you talked about leveraging natural partnerships that are already there, and how do you leverage these things to build strength and capacity in other areas. And Julie, you talk about new and durable relationships, and this idea that some of these things which were put together as we need to do this now might have real advantages going forward. And we'll talk a little bit about that later, of what was good and durable that came out of a response to a pandemic might be something that lasts in your organization. So you've each talked quite really thoughtfully about healthcare providers, about your healthcare workforce. And of course, for each of you, it's a different group workforce. There's lots of commonalities, but you also have different essential and frontline workers. Can you, and I do want to remind, just before I ask the question, sorry, for audience members, for attendees, you have an opportunity to put questions now into the Q&A chat if you want, for when we get to the Q&A part, probably in about 10, 15 minutes. So if you have questions, and I'm sure you have lots, please don't hesitate to put them into the Q&A section right now. And once we get into that, we'll have a look at them. So going back to thinking about healthcare workers and your staff, those who you're responsible for, we've heard a lot over the last 15 months, a lot of narratives about healthcare workers, about heroism, about exhaustion, about burnout, about deep moral distress, alongside calls and needs for more different kinds of supports, both in the moment and looking ahead. In terms of supports that have been put in place for your workers, for your workforce, is there one thing in particular that you think has been particularly important in your organization in this regard? And that you might see as especially important going forwards in terms of supporting your workers? Anyone want to take this first? I'm happy. Maureen?
Sure, I will. And I do want to mention, as we're always so focused, obviously, on the pandemic and the health human resource shortage, but we also have to acknowledge, this existed before the pandemic. And so it was already at a crisis, I'll be honest. And then, then the pandemic hit. And so, our healthcare, our workers and our teams, at all levels, right? Definitely, they're very, very resilient. And we should be proud of each and every one. And those that are suffering some, with some burnout or additional stress, they have to take the time to care for themselves. But one thing that struck out for me, and we actually have some really great outcomes from it, is that, a couple months into the pandemic, right, we did see, the sort of the stress and fatigue, both on our managers as well as our healthcare workers, right? PPE became, part of their wardrobe. And so what we developed and implemented was a PPE safety mentorship program. And that was to ensure that, as we're fatigued, right, they're working long hours, that we just stopped and did that safety check. And we had peer-to-peer support in doing, and actually what John, you described there with your PSW, and she was teaching you, is exactly what we were trying to create. And we called it, as I said, the PPE Safety Mentorship Program, but that really took off. And in November, we actually did an engagement survey of our staff, and over, I think, 1,700 staff had responded, and 98% of them felt they knew how to properly don and doff PPE, and they felt safe. Like, I was a surveyor for many, many years, and work-life survey results, I've never seen anything so impressive. But that was the result of them taking that extra step, and as well as their manager and leader to support them. And we're talking, I had one instance where one of our clinical managers and area director actually went and drove and met the PSW outside of the home to do the safety mentorship with them before they went in. So that has, stuck out in my mind. That really was a game changer, and we'll have to continue to do that on a go forward basis.
Thanks, Maureen.
Maybe
Julia.
Nancy, if I can make a comment, the other thing we know that also took place over the course of the past 14 months is that some have called the racial reckoning, or the many racial reckonings. And I would say one of the things that was really important that has taken place, particularly with the rise of anti-East Asian racism, was creating safe space opportunities for our Asian staff to come together and talk about their experiences, both mostly externally to the organization, but their experiences during the pandemic, and the ongoing impact of that on their ability to do their work. In the aftermath of the murder of George Floyd back last late spring, we brought our Black identified staff together similarly, and identified a number of priorities around anti-Black racism coming out of those discussions. So there's been these multiple impacts on our clients and families and our team at the same time as the impact of the pandemic. And I think one of the hardest resource challenges is how do you figure out how to address all of those needs at the same time, knowing that people are very, in some ways similarly situated, but in some ways very differently situated as they experience the pandemic.
Yeah, thank you, Julie. Do you want to jump in there, John?
Thanks, Julia, for mentioning that. I was going to touch on it, but perfect job. I'll just add families. And so we don't define them as staff, but we view them, and I think Maureen and Julia would 100% agree, they're an essential part of the care team. And so for Directive 3 from the government, right at wave 1, it was restricting no visitors, no family, no nothing. And we struggled with it. We really struggled on honoring the public health measures, the government directions, but also recognizing the plight of our families and being separated from their loved ones, potentially for months. And I got a lot of angry emails and phone calls. So, met with the team. The team is like, what are we going to do here? We're caught between a rock and a hard place. We don't want the ministry inspectors to come in and slap us with non-compliance because we have family members coming in, even though we know how valuable families are. So the team came up with what I thought was a great idea, and this is related to staff morale and staff support, as families are all those things, is the team came up with a creative solution. Why not employ them? And I was like, yeah, like that will ever happen. The lawyers, I can see the lawyers cringing, but our labor lawyers said, what's stopping you? Our labor partners, our union said, great idea. This is all in 24 hours. We had 10 families come. We hired them at $17 an hour. Their job was not only to take care of their loved one, but to take care of the entire unit, which they knew anyways, since most of them visit every day. And so they worked there on 90-day contracts. All of them donated their salaries back to us. And so I think this was just a great way to support our staff, support our families, and more importantly, support our residents.
Wow, thank you. So we're there's a lot of, we could probably have had this panel be about 4 or 5 hours, but we only have an hour. So a lot there from all three of you, and really appreciate your answers there. I'm gonna kind of skip to a question at the end that we were going to sort of ask at the end, and then I would love to dig into some of the questions in the Q&A because there's some excellent questions there. You really talked a lot about things that you've put in place, things that were already in place, and how you're thinking about going forward, whether it's about families and patients, whether it's about staff, whether it's about just organizational and leadership values. But do you think that, or can you talk about one way in which you think your organization is going to come out of the pandemic stronger than it was before? In any particular, and I'm kind of picking up on Julia's answer to the last question about creating safe spaces and opening up something which, you know, probably was already being done, but now is being done in a different purposeful way. Is there some way in which you think your organization might come out stronger, given that there were already challenges, given that there was already lots of resilience and strength there, given that that's been tested? But does anybody want to start that one, Julia?
Let me start off briefly, because I know we're running out of time, and I'm going to draw on one of John's examples, and that was internal redeployment. And we all, in all of our organizations, experience organizational silos. And, you know, there was lots of resistance to that internal redeployment in the early days. You know, I had nurses coming from, you know, nurse practitioner coming from an ambulatory area, hadn't worked on a ward in 40 years, and never worked on a ward in Canada, and never intended to work on a ward again. And then the same nurse a few weeks later, I'm talking to, you know, in the screening line, and they're telling me how much they've learned, how much expertise they brought from their ambulatory experience that the unit has really benefited from, and what they've learned at the unit that they're going to take back into their clinic once they're able to. So there are things that we've learned that have, I think, will be durable. The other example I'll give, and I saw one of your questions in the Q&A, is around communication and building trust. And I'm doing weekly all staff bulletins every Friday. I'm doing virtual town halls every couple of weeks. There is a lot of, I think, increased leadership communication, vulnerability, admitting of mistakes, admitting of not having the answers. And I think there is a sense, like there never has been before, of trust, of a sense that, you know, it may not be right all the time. In fact, it may be lousy, and bad decisions may be made, but we're doing them together as best we can. And I think that trust actually in those relationships will make us stronger over the long run.
Thanks, Julia. And I've heard that from other leaders as well, this sense of showing vulnerability, communicating more. The trust is different. There's a different quality to it, and showing your humanness and your authenticity as a leader, saying, I'm struggling, you know, we're struggling together. So appreciate that. We're going to head into some of the questions from the attendees, and I want to first thank people for such thoughtful questions. I'm going to combine two of them, and I'll open it up to any of the panelists. There's two questions sort of on influence. One is, you know, as leaders, do you have any thoughts or recommendations on how to influence politicians in order to, really enact legislation and policies that are thoughtful, ensure patient and staff safety, or whatever the priority might be? But so influencing politicians, but also, do any of you want to take this other question in influence, which is, what can staff at organizations do to influence leaders like you when they see that there's problems or they see solutions? Whoever, John, do you want to, you look.
And thanks, Brandon. So Brandon, who asked that question, is just started this week. He's a MBA student intern. So top shelf there, Brandon. Good start. Very impressed. I'm gonna try to answer your question. So around influence, I think there's the traditional and then non-traditional. And traditional, get in front of the minister, minister staffers, chief of staff, MPP, deputy minister, assistant deputy ministers, the bureaucracy. I mean, that's the traditional. And there are different tables, different avenues, different lines in, depending on your sector, whether you're hospital, home care, or long-term care. There's different ways in. I think all of us, Maureen, Julia, and I, have done it, are doing it, and we have teams that are doing that. The non-traditional, which actually should maybe be more modern, I should rephrase it, modern, is leveraging public perception, public attitudes, social media. If you go on Twitter today, it's just kind of like, holy crap, it's actually too much. But politicians, their staffers are following that. They're getting a pulse generally of what the population is thinking. Mind you, Twitter may be a subsegment of the population, and there's some ugliness in social media, so you got to kind of parse through that. But if you go through it, there's actually some valid points on the topic of the day, whether it's vaccinations, whether it's reopening the economy. The public will weigh in. And I think you can influence that through social media elements as well.
And I would just add to that, I think another great strategy to influence leaders and politicians or just one another is really using evidence. So whether it is, scientific evidence to really articulate the reasons why, or just even, some leading practices or good practices. And that when we don't have enough evidence, we have to lead with the precautionary principle, do whatever, all of the above until we know what we're dealing with. But definitely, I would say throughout my career, the more you can back up your position with some facts, it helps to get the ear of people.
Anybody want to comment on how staff can help influence your decision making that needs to be made at your level? Are there new or interesting or effective ways that you can talk about?
Really, it's such a great question, because I think that it's not so dissimilar to what John just described in that, and Maureen as well, in that we're looking for solutions. And I think we're coming to the problems we're facing are enormous. And as I say to my team all the time, I've never had to solve these problems before. None of us has ever had to lead through a COVID-19 pandemic before. So anything you've got, that you think is going to solve this particular problem, bring it on. And so I think the openness, humility, creating an atmosphere where people are confident that they can bring forward solutions is what we're all trying to do. And I think that's the opportunity for influence, is not so much, sometimes our muscles for complaint are very well developed, but our muscles for problem solving may be a bit atrophied. And if we can exercise those muscles of problem solving, solution focused, I'm ready to try pretty much anything because the problems are so big.
Mm-hmm.
Right.
And I think it goes back to your earlier comment, Julia, about, trust, right? Really fundamental to that is building a culture of trust where people at all levels, in all positions, feel safe to speak up and to bring forward. And that's where I say, no question or no idea is a stupid one. It's all about working together, but it's the trust and that psychological safety that really is critical to success. Yeah,
so there's such good questions in the Q&A. And I want to just go a little bit, it's personal, but it's about really leadership. Are there some things that you've all talked about going above and beyond in your own way, in different ways, on just being pushed and, doing more communication, doing more outreach, being more accessible and showing your vulnerability. Can you talk a little bit, anyone, about some of your own coping mechanisms that obviously you've shown tremendous resilience, as your organizations have, to get here and be here today and smiling. What are some of the coping mechanisms that you've either put in place for you and your staff, or you've done yourself to get yourself through these 15 months?
I think for myself, it's always just leading with that sense of purpose and cause. I can tackle anything as long as, I have that greater sense of purpose. And a pandemic has called that call to action, absolutely, not just with myself, but I think in every individual, absolutely in healthcare, but outside of healthcare. I mean, if you think about our teachers, like, look at the world that their world is just fun, and now they're trying, they're online, hybrid, online, in school, and that's resiliency as well. And I think we have to recognize that this has brought out the best in people. Unfortunately, in the media, we're always reading the bad stuff, but I think now, and I'm working with my teams to say, let's focus on those positive stories, right? Celebrate all the good, because it's easy to get focused and bombarded on the bad or the negative, or we should have done this. Let's be grateful what we have achieved.
Yeah, I'll add, besides my family, in terms of my own coping mechanism, the day after the WHO declared a pandemic, I decided to tackle this project. I'm a runner. I call it #RunEveryStreet. And I've decided to run every single street in the city of Toronto, the full city of Toronto. I'm only at 15%. Which equates to almost 3,000 kilometers, but I've been doing it 3-4 times a week. This morning, I came to work at 5:30 in the morning. I ran 18K into South Liberty Village, as well as Parkdale. And I think just by doing different routes, so before the pandemic, I just run 6 routes, the same 6 routes every single time. I have not run the same roads twice in a year. And I think it rewired my brain. So when you're dealing with these massive problems, it was the same thing. I wasn't thinking about it in the same way. So my neurons were rewired, and we tackle these problems in a very, very different way. So it actually gave me insight of looking at a problem differently. But it was also a way for me to cope, and I'm still doing it. I still think I got like 6 years left of doing this. My wife's going to kill me, but I'm going to finish it.
That's great. You realize as development of the city increases, it's a never-ending project. Julia, do you want to chime in? We'd love to hear from you too.
Oh, sure. Quickly. I mean, I'm on vacation this week, and that's a kind of leading by example thing. That I can be off, and I have, I'm not looking at email. I'm just really trying to be off. I'm baking, I'm exercising, I'm reading. And I think when, sometimes our managers find it really hard to take a day off, they find it too much. And I think if they see the CEO say, okay, I'm stepping away from email, I said it on my Friday all staff email, hey, you're not going to get an email next Friday because I'm taking the week off. And so I think that's part of it. And the other part I'd say more professionally is trying to think about the cool, big things we want to do that aren't about COVID. There is an after. There is more strategy to happen. There are more needs that are emerging. There's big work yet to do. And I find for many of my staff, that is the break they need, is we still have this goal, and we're still trying to get there, and we can still make a huge difference in, whatever the particular thing is. And I think that really helps people to get out of the day-to-day and keeps us focused on big picture motivation, like Maureen said, values. Why do we come to work every day? It's those big problems. It's changing the lives of kids.
Wow. So all 3 of you, you've been just amazing. I I want to say to all the attendees, we didn't get to all your questions. They were great. We appreciate their thoughtfulness, and they were, as I think John said, top shelf, but we couldn't get to all of them. So appreciate you being here. Chris, I'll hand it over to you for a final word of thanks for these great panelists and their time today.
Sure. Thank you. First, just thank you to all of the panelists and our moderator, Nancy and Maureen and Julia and John, for giving your time during what is a more than slightly busy time of your lives, and Julia for showing up while you're on vacation, and giving such really amazingly insightful and useful answers to those questions. As Nancy said, we could do this for hours, but and we may well invite you back for a part 2 at some point. But so on that note, and I also just wanted to thank all of our attendees. We had a tremendous turnout for this topic. I think it's in some ways not surprising, because it's a topic that it's some of us who never thought much about ethical issues in health administration and health management and health leadership have spent a fair bit of time thinking about it over the last 15 months. So thank you all for attending on behalf of the Ted Rogers Leadership Center and the Canadian Centre for Ethics and Corporate Policy.